Thank you for inviting me to share my thoughts on this very crucial, important, but often neglected or overlooked topic of adult vaccination. Well, this is a Shingrix. It's a Glaxo product. The slides have been prepared with help of Glaxo. There are my inputs. Of course, there is no major data management. So the scope of presentation is, we'll try to discuss prevalence of herpes zoster in comorbid conditions, the efficacy and safety of Shingrix vaccine, and the indications of Shingrix vaccine. Well, so this is how we'll go. We'll go as far as herpes is concerned with comorbidities like diabetes, COPD, a cardiovascular disease, the efficacy after the age of 50, the trials supporting this efficacy of Shingrix vaccine, and the safety of Shingrix vaccine, and the recommendations of international bodies about herpes Shingrix vaccine. So we all know that herpes manifests and gives a very disastrous time to a lot of patients. I'll start with 3 cases that I saw in last few days. A 65-year-old female had pain in left lumbar region, for which she was rushed to a urologist by the relations, considering it was a renal colic. He did a lot of tests, a sonography, CT scan. He did not find an evidence of calculous disease, sent her to a gastroenterologist to rule out a GI issue. The gastroenterologist did upper GI endoscopy and found out that there was hiatus hernia and advised treatment for hiatus hernia. This was day 1 and day 2 of the disease. She had comorbidities like ischemic heart disease, hypertension, obesity, cholelithiasis, uricemia, and so on. Typical patient with obesity. Day 3, the patient had rashes starting from lumbar region, developing severe pain, rashes. She was diagnosed to have herpes zoster, treated with acyclovir, still continues to have severe pain and is gradually recovering. This is the second patient. She returned from USA and she had severe left leg pain which was attributed to a sort of lumbar spondylotic radiculopathy because she had lifted bag during transit. She was about to be rushed for MRI. Third day, she developed, despite not responding to non-steroidal anti-inflammatory drugs, third day she came with these rashes, was diagnosed to have herpes zoster and was treated with antivirals. This is the third patient whom I have been treating since 2012. And that point of time, a diabetic patient had herpes zoster, neglected it, considering that it was some bite, did not took any treatment, went on for about a week or so, and then came to me. We started antiviral treatment. Little later, he wasn't too comfortable taking treatment, and even now, so almost 12, 13, 14 years after the episode, he continues to have severe post-herpetic neuralgia affecting quality of his life. These are 3 cases. We see day in, day out, all of us see. We see their complications, we see the presentation, we see the pain. And therefore, it is imperative that we learn more about herpes zoster and the way it presents to us. Herpes zoster, as is known, is usually the virus is present in latent in neural ganglia. As age advances, as immunity goes down, there is a decrease in specific cell-mediated immunity, and this in turn leads to zoster virus reactivation. There is an increasing prevalence of herpes zoster because of age, comorbidity, immunotherapy, and various other factors. The common complications, as we see, are post-herpetic neuralgia and herpes zoster ophthalmicus. If you see this data across the world, if you see there is a very high prevalence of herpes as the age advances. Right from the age of 50, there is a peak in incidences of herpes, and that goes to a peak in the 70s and 80s. So as age advances, there is a higher prevalence of herpes zoster. Therefore, a senior citizen is more likely to have herpes zoster. This is the data from Asia. If you look Taiwan, Japan, China, again, there is a peak in incidence of herpes after the age of 50. So roughly 50 and early 50s is a trigger for herpes zoster reactivation, symptomatic presentation, and therefore we need to be very cautious and vigorous in detecting and treating them. If you look at comorbidities and psychological stress affecting herpes, disease like depression, asthma, diabetes, chronic kidney disease, cardiovascular conditions, COPD, each of them can increase prevalence of herpes zoster by 1.29 to 1.41 times. So typically a patient of diabetes is likely to have more incidence of herpes zoster, so a patient of cardiovascular disease, so a patient of COPD. In fact, psychological stress and physical trauma itself can double the incidence of herpes zoster. So comorbidities do create problem. If you have two coexisting comorbidities, a diabetes and hypertension, COPD and congestive heart failure, diabetes and a cardiovascular disease or heart failure, there is almost doubling the incidence of herpes zoster. So if you look at herpes zoster in a patient just with one morbidity like a diabetes, the chances are 2 to 2.5 times. As there are two diseases like a heart failure or ischemic heart disease or a COPD, this becomes double. In short, one disease can lead to high incidence of herpes, and if there are 2 or 3 comorbidities, the prevalence of herpes goes up remarkably. Lots of patients come to us and say that I had herpes zoster 20 years back, 30 years back. Are there chances of me having a recurrence of herpes? Do I need relapse? And if it is seen that in patients of chronic kidney disease, dyslipidemia, diabetes and hypertension, there is almost 22 to 35% or 40% high chances of getting a herpes recurrence at any age. And as age advances, after the first episode of incidence of herpes zoster, around 5 years down the line, there is a very high chance of patient getting a recurrence of herpes. So herpes is not a disease which gives you lifelong immunity, and therefore it's very important that we be very vigilant about recurrence of herpes, even in a non-immunocompromised, that is a patient having reasonably good immunity, but having comorbidities. So if you look at diabetes, just how diabetes can predispose to herpes zoster. We all know the immune system, the adaptive immune system and innate immune system containing of physical, chemical barriers, and the adaptive immune system consisting of cell-mediated response and humoral response. So typically we have cellular immunity and humoral immunity, which protects us against viruses, bacteria and infections. Now in a patient of diabetes, there is disordered humoral immunity and impairment of cell-mediated immunity. There is a T cell imbalance, there is high CD4, CD28 cells, low CD4 cells, leading to adaptive immune system dysregulation. Long-term hypoglycemia leads to polymorphonuclear cell apoptosis, increase in inflammation, pro-inflammatory cytokines, and therefore there is dysregulation of innate immune system. And there is a diminished innate immune response system because of various dysfunction of polymorphonucleosides, monocytes, and macrophages. Therefore, a diabetic is typically having a high risk of having herpes zoster. There is an insulin-degrading enzyme, which is now considered to be one of the causes of insulin resistance, and that the enzyme itself can lead to a higher incidence of herpes zoster. And therefore, if you look at various meta-analyses, large cohort of patients, million patients, if you see here, in type 1, type 2 diabetes, and these are meta-analyses, 14 and 32 diabetic studies, in patients of type 1 and type 2 diabetes, the pooled risk ratio showed there was 1.30 and 1.24 times. So that is 30% and 24% higher prevalence of herpes zoster when there is diabetes as a coexisting morbidity. Now, if you look at complications of post-herpes, that is post-herpetic neuralgia, and this is a large cohort in Asia. If you see at more than 100,000 patients, those having diabetes had very high prevalence of post-herpetic neuralgia to the tune of 19 to 70% more. So roughly 1.5 to 2 times higher prevalence of post-herpetic neuralgia, showing that diabetes predisposes to herpes number 1, and there is a very high chance of post-herpetic neuralgia. Herpes zoster itself may also lead to disruption in glycemic control with worsening of A1C, worsening of fasting and PP2 blood sugar. So patients with diabetes are more prone to herpes and more prone to herpes complications. If you look at a typical care of a patient of diabetes or herpes, in the United States, for example, a patient of herpes may end up requiring budget of 25,000 because of various reasons, the drugs, the hospitalization, the rest, and so on. If there is an association of diabetes, that cost goes up by almost 25%. So when there is a coexistence of herpes and diabetes, the healthcare cost, the delay in recovery, the hospitalization, or the rest period goes up, and therefore diabetes is a bad marker in a patient of herpes zoster, and vice versa. What about chronic obstructive pulmonary disease? And we see a lot of chronic obstructive pulmonary disease nowadays. Chronic obstructive pulmonary disease now is considered to be an advanced aging phenotype, meaning thereby that a patient of COPD at the age of 40 would have a body physique of roughly 60 or 70. There is a decrease in COPD associated with impaired systemic cell-mediated immunity. There is decreased cytotoxicity of peripheral natural killer cells. There is reduced phagocytic activity of monocytes, macrophages. Over and above that, the patient of COPD are much more frequently likely to be on either inhaled or oral steroids, impairing their immunity much more than expected. And therefore, when there is already an existing immune dysregulation because of COPD, add on to that the intake of oral or inhaled steroids, there is a higher prevalence of herpes zoster in a patient of COPD. And if you look at these large cohorts, 8,000 patients, more than 50, the prevalence of herpes was 67% more in patients of COPD without steroid usage, almost 2 to 3 times higher prevalence of herpes zoster in patients of COPD who were on either inhaled or oral steroids. And therefore, if you look at the hazard ratio in another cohort, it is almost 45 to 61% more. The COPD patients using inhaled oral steroids are even at greater risk of herpes zoster, and they also have a higher risk of having post-herpetic neuralgia. So if you look at the healthcare resource requirement, the hospitalization, the treatment, the morbidity is extremely high when there is coexisting COPD and herpes zoster. Now if you look at cardiovascular disease, and we see a sort of epidemic of cardiovascular disease, ischemic heart disease, heart failure and whatnot, reactivation of varicella zoster virus in sensory or autonomic ganglia, this reactivated virus then goes to cerebral or coronary arteries. There is influx of inflammatory cells leading to release of enzymes and reactive oxidation species. There is a high inflammatory cytokine prevalence. There is a systemic inflammation, altered immunologic status, increased sympathetic tone, and therefore, because of herpes zoster, a patient of pre-existing cardiovascular disease, maybe hypertension, ischemic heart disease, or heart failure, will have vasculopathy and a very high incidence of stroke or myocardial infarction. So, herpes zoster infection was linked to 1.35 or 35% higher chance increased risk of myocardial infarction. There is a direct damage to myocardium because of virus leading to vasculopathy, myocardial cell damage, and in some patients, it could either lead to atrial fibrillation or a permanent pacemaker implantation because of complete AV block. If you look at in this cohort, which was studied in 2014, if you look at coronary artery disease in patients when they were followed, herpes zoster patients were followed up from 2 to 8 years. Between 2 to 5 years, there was a higher prevalence of hazard ratio or higher problems with ischemic heart disease after onset of herpes zoster, and that was as high as 14 to 15%. And therefore, if you have to know into crux what is the relationship between herpes zoster and cardiovascular disease, there is a patient of herpes zoster has almost 30% higher long-term risk of a major cardiovascular event. It could be an infarct, it could be acute coronary syndrome, or congestive heart failure, a permanent pacemaker, a block, AV block, or atrial fibrillation. There could be autonomic dysfunction affecting the nerve ganglia and high risk of atrial fibrillation. It could lead to cerebral ischemia.
Last 2 minutes, sir.
Yeah, and this is more so when the patient is on immunosuppressive treatment. So this is an interaction or vicious cycle between herpes zoster and various diseases. Shingrix, the vaccine that has been recommended, the trial which was published in 2015, ZO50 and ZO70, this was in patients between 50 and 70, this was in patients above 70, showed the efficacy of this vaccine in the population at large. If you look at prevention, above the age of 50, there was almost 97% safety or efficacy of this vaccine, and after the age of 70, the safety and the efficacy was to the tune of 91%. If you look at long-term follow-up of 11 years, the safety was almost as high as 80, and in some population, 88%, showing that this is a very efficacious vaccine. A patient of hypertension, dyslipidemia, diabetes, etc., all chronic patients do require herpes protection, and Shingrix is the right way to prevent it. Almost all international associations, it is CDC, this is from USA or ADA or American Family Academy, have recommended Shingrix vaccine in patients above the age of 50. If you look at Indian data, API, Research Society for Study of Diabetes in India, strongly recommends the use of herpes zoster above the age of 50, and especially 2 doses. It is the drug which is a vaccine approved in more than large number of countries to be given as 2 doses over a period of 0 and 2 months. Intramuscular injection, the safety profile is reasonably good, compatible with other vaccines like influenza, pneumococci, and Tdap. The side effects are very minor, like pain, redness, swelling, fatigue, fever, headache, which are commonly seen with any vaccine. And this vaccine has great efficacy, less side effects, great impact in survival. So these are recommendations. I very strongly recommend that. I would urge all of you to recommend herpes zoster vaccine Shingrix to almost all patients above the age of 50, especially when there is a coexisting comorbidity. Thank you for your patience.